Good morning, everybody. Thank you for joining us for another APSAD Insight webinar. My name is Jim Hunt and I'm one of the nurse educators here at Insight, and I'm going to be your MC for this session. This session's a bit different to what we normally do in our webinar series. So this is part of the QScript series of webinars that we've been running. So this is a new system that's coming into Queensland hopefully later in the year. And this is really training sessions or the ability for GPs to upskill in this area so that they're hopefully going to be familiar with how to manage not only the system, but the clients that they might see in front of them when they're looking at this system. So whilst it's mainly aimed at GPs, we're hoping that it's also going to have information in it that's going to be useful for other clinicians, because we're going to be talking about a difficult situation that a GP might face today in their practice. Before I go any further, I'd like to acknowledge the traditional owners and custodians of the land on which I'm presenting today. So I'm in Brisbane, or Meanjin, so home to the Yuggera and Turrbal people. I'd like to pay respects to elders past, present and future, and I'd like to extend that welcome and respect to any Aboriginal or Torres Strait Islanders that might be joining us out there in webinar land. So thank you. Hopefully it's going to be a good session today. It's something that we've not done before. We're looking at organising a panel today, so it's going to be a panel discussion where we're going to present a clinical scenario. We're going to get to learn a little bit about a gentleman called Daniel, have a look at his presentation, and then with our expert panel, we'll look at some of the strategies that might be useful in how you might manage that person if they were to come into your clinical practice. There's going to be an opportunity for you guys to engage with some questions at the end. And if you click on the chat function and open that box, by all means, type your questions in there as we go through the scenario. And then we'll get the opportunity to put those questions to the panel at the end of the session, if that's okay for you guys. And also don't forget, there will be a feedback survey at the end. And I'm sure the panelists that are going to be joining us today would be interested to get some understanding of how useful this session might have been for you. So without much further ado, I'm going to introduce the panel and then we'll get on to the case study. So for the panel today, we've got Dr. Geraldine Chew. Dr. Geraldine Chew. Oh, sorry, Geraldine. She's an addiction specialist and a general practitioner. She's a graduate of UQ, works as a medical officer for Metro South Addiction and Mental Health Services, Bayside Alcohol and Drug Services, Logan Alcohol and Drug Services, and the PA Hospital Pain Rehabilitation Centre. She has a small private practice in addiction medicine at the McCulloch Medical Centre, and she works for a group GP practice at Sunnybank Hills. She also volunteers for the Cancer Council Queensland after having cancer herself. She's married with 2 adult children and a large extended family who are closely connected. She enjoys her job, her family, her friends and life itself. And I've got to say, looking at that resume of work, I'm amazed she has any time left to enjoy life. But please say hello, Geraldine, so that people know who you are.
Hello, everyone.
Thank you, and we will come to you again in a minute. Next on the panel, we've got Melanie Proper. Melanie is a pain management nurse practitioner for 10 years at the Royal Brisbane Women's Hospital, also working at Recovery Medical and the Y Clinic, and has been working in the field of pain management for over 20 years, so is no doubt going to have some useful things to add to this presentation today. If you'd like to say hello, Melanie.
So the spacebar thing didn't work.
Thank you for that, Mel. And as I say, this is also a bit of a practice to get us into the rhythm for what's coming up today. And finally on the panel, we've got Joy Gailer. Joy is an advanced practice pharmacist with the Drug and Therapeutics Information Service in Adelaide and a general practice clinical pharmacist. Her work with general practice involves developing clinical governance frameworks for the care of patients requiring opioid therapy for chronic pain. Joy also has some insight into real-time prescription monitoring since South Australia rolled out their system Script Check, and she can share some of these experiences with you today. And I can also add that Joy is also a famous rabbit wrangler, I learned this week, as she escaped bunny earlier in the week. Do you want to say hello, Joy?
Thanks a lot, Jim, and good morning, everybody from South Australia. We've got a beautiful day here. I hope it's beautiful up there as well.
Nice. It was certainly lovely when I came in. I'm now in a cupboard, but I'm hoping that it's still lovely and sunny outside. So thank you, guys. And we're going to have a look at the case study, and then I'm going to pose some questions, and the panelists will get the opportunity to respond as they feel fit. So let's have a look at Daniel. So Daniel presented to his GP as a new patient. He has unfortunately come with only minimal documentation. He reports that his last doctor, who was managing his care for years, has retired due to illness, and he's found that no other doctor wants to manage his case. He even has approached his specialist for support, but was unable to get an appointment at short notice. Daniel is 46 years of age and advises you he is getting concerned as he's actually running out of his medication and so needs to continue his supply. So he wants to see you urgently. Daniel has a long history of chronic pain post a motor vehicle accident in 2012. He says that since then, life just has not been the same. He can't function or exercise. Daniel states he's put on 15 kilos and has begun to experience secondary mental health challenges. Recently, in March 2021, Daniel tripped while walking to answer the phone and sustained a fracture to his left foot. Daniel's surgery was delayed for a month due to lockdown, and despite happening earlier in March, he's still wearing a moon boot, despite being told to stop using it. He states he's still struggling with the pain. Daniel is awaiting an orthopedic review and is on the list to see his pain specialist. Now, from the history that you can see in front of you, we can see that Daniel has a body mass index of 32, which places him in the obese category. He's also developed type 2 diabetes since 2018 and has been experiencing an affective issue, i.e. depression, since the motor vehicle accident in 2012. He's reporting non-specific lower back pain post that same motor vehicle accident. He's living with his long-term partner, Marie, has 2 teenage dependents. He's currently unemployed, but previously used to work as a financial consultant until the accident, and then work cover, which was settled after the accident, sorry. Daniel is waiting for an orthopedic review for his left foot fracture, on the waiting list to see a pain specialist. What about his medications? And this is the stuff that will be appearing on QScript that people will have access to. And as you can see, he's presenting with several medications. The doctor was actually able to verify that Daniel's monitored medications history via QScript and matched what he was saying. He's provided accurate records of his current dosing regime, including his opioids. So for many of the people that are tuned in today, you may not be aware of all of these medications. So tramadol, oxycodone, and tapentadol, those first 3 on that list, are all opioid medications. And as you can see in the top right, and this is something that will happen with QScript, when certain things happen that can be considered risky, alerts will be raised on QScript. And this one's raised an alert because of the increased risk of overdose. And that's because the total of those 3 opioids that is currently prescribed would total the oral morphine equivalent of 100 milligrams or more. They actually, so oxycodone and tapentadol there will equate to about 130 oral morphine equivalent, and then you've got tramadol on top of that PRN. He's also got some pain relief from paracetamol and naproxen, and he's on an antidepressant, the sertraline, and he's also got some diabetic medication there as well. He reports, as I said, that he's almost out of his medication, and so obviously he's getting worried as he feels that without them he won't be able to get through the day. So Geraldine, I'm going to go to you first. This sort of thing must happen to you fairly regularly in practice, inheriting patients. Like many GPs, time is obviously a huge barrier. You have about 10 minutes to conduct a consultation and deliver some treatment for. How would you approach Daniel in relation to this high-dose opioid alert that has been triggered on QScript? And would you feel comfortable to continue his request of his current prescribing regime?
Right. A red alert does not mean that you cannot prescribe for the patient. It's simply a warning that there may be a high-risk clinical situation which requires additional attention. I would reassure Daniel that I'm there to help him, but I would definitely require more information about his medical conditions and how his medication history has progressed over the years since his motor vehicle accident nearly 10 years ago. This would require time, so I would ask him to return for regular consultations in the following days and maybe weeks to prepare care plans, one of which would include an opiate medication review. I would inform and provide him with some pain education with regards, inform him about persistent pain management education, that high dose opiates are not indicated in the management of chronic pain and that there are many other modalities just as important or more important to manage his pain, such as psychological, physical, and social treatment. I would prescribe for his opiates, I would ask him which medications he's running out of, because he is on other pain relieving like pregabalin medication as well, and paracetamol. I would prescribe one opiate for him. I presume it would be out of the 3 opiates he might be concerned about, and cease the 2 opiates. I would give him a higher dose of the opiate to prevent opiate withdrawals, or perhaps even rotate him to one long-acting opiate medication. I won't go into detail for that, but we can talk about that later. I would give him 1 or 2 days supply of the opiate and review him practically daily to check on the progress with respect to pain and opiate withdrawals. The important thing here is to establish a rapport with Daniel and be non-judgmental, because he's not going to listen to you if you don't believe his story and if he doesn't feel that he's being heard. I would acknowledge that he has genuine medical issues such as pain, diabetes, depression, reduced physical fitness, or sometimes we use the word physical deconditioning. His muscles are weak, they're no longer strong, and obesity. All of these issues need to be addressed as they all impact on each other, and it's not just as medications that I would focus upon.
Yeah, so adopting that holistic approach rather than
That's
just
correct.
literally focusing on pain. And do you think he would get nervous, because obviously he's already nervous about his medication running out, and to go through that discussion of we're now going to actually make some changes around your opioid use, is that not likely to increase some anxiety for him, do you think?
Yes, it would increase his anxiety, and that's why I say it's important to develop a rapport to make him understand that you know what you're doing, that you're there to help him. If he's going to be distressed, it's only for a day. I'll see him again the next day. So it's not a long, and what would reassure him that increasing the dose of one of his opiates would alleviate any potential withdrawals. I would also actually ask him, he might say that he's running short, but he may have run out of his medications completely. It's opiate medications I'm talking about, and could be in withdrawal. And if he's in some opiate withdrawal, when I see him, I won't be giving him any of those 3 opiates that are listed. I would perhaps give him a different opioid, such as the Norspan patch, which I feel is a very good option for him.
Certainly. Thank you, Dr. Geraldine. I'm going to go to you, Melanie, now. With your expertise in pain management, how would you keep Daniel engaged in treatment and provide other non-opioid treatments to support him to manage his pain?
So I think the thing to keep in mind for Daniel is that he has a 10-year history of dealing with his pain, healthcare providers of many ilks, and obviously has managed to get his medication, when you look at that list, escalated. You know, it rings of someone trying to manage him and his behaviour maybe over the time frame, and added this and added a bit of that, but really no comprehensive plan. So he's been given lots of information, probably some of it quite confusing, and he'll have lots of reservations around any healthcare professional and his pain management. He will be very skeptical. So that really needs to be understood going in. And in a GP setting where you have a short appointment time for someone so complex, especially with all those comorbidities, you really need to break this down into small parts. And initially, I think, even though my overwhelming desire would be to make lots of changes very quickly, I think that would be counterproductive. I don't think he'd come back if you behaved like every other health professional in his view. So, and I think understanding that what his history is a little more. So having a very clear level of his idea of his level of function. Is he spending his entire day in a Jason recliner and not really walking anywhere? Does he have any hobbies, interests? Is he doing anything? Because in reality, he was a financial advisor. Why would a back injury stop him being able to stand at a standing desk? You know, there are lots of warning things in that history that you need to understand. What pharmacology, non-pharmacological things he's had before that haven't worked. And I always like to do a brief pain inventory, and I often give the patient completing out lots of colours and pens and things to complete it with, because sometimes that can be very helpful if they have multiple pains and concerns. And it's a very useful way of measuring now. And then as your care and your progresses, you when he doesn't think he's doing very well or is getting despondent or having a low moment, bringing out the previous you know, where he's coloured in the diagram, saying, well, you know, you can see this is different. You can see
using it as a reflection
in your head. So those sort of assessment tools are very useful. They can be a little bit time consuming, but they can do them before they come into the room. And they really help sort of track your process and make sure that you'll be both using similar language, and also give you cues about neuropathic pain, which is a little unclear, but he's on some of that medication. So maybe some more useful information. And then I think he really needs contemporary pain education. He's, you know, his original pain was a very long time ago. His behaviour is all fear-based, keeping his moon boot on, seeking more medical opinions, despite what he's already been given. He's operating from, you know, he's afraid he's broken and he's going to break more. And probably the biggest achievement for this initial session, maybe just that history, and to get him to understand that he isn't going to break more. While that is what pain's role is, sending you a message that tissue is about to be injured, it's actually a false message at this time for him. And that's because pain changes your brain. It changes the way your nerves operate. It changes the way your brain processes information. And being stressed and being in pain and being on opiates actually increase that exponentially. But the good news is that it can be reversed and changed. And that happens through education, support, and managing those other stresses that are increasing his pain. So you need to really get him to understand that you're after a quality of life change, that you're unlikely to be able to manage all of his pain, but things can be very different. And that's about chipping away at all of those elements of his pain. And particularly managing his stress response and his pain inhibition. So his poor gaiting, his poor movement, his deconditioning, they are all adding particularly to him. And then just a little bit of, you know, so opiates help you, do they help your pain? And often when you ask patients a very straight question, they'll say, actually, no, not really, because he's been on these and they're at reasonable doses. And his pain is still poorly controlled, he can barely walk. So even just getting a little bit of light into that darkness can be quite useful for patients. And then establishing, you know, a functional and a treatment goal, so that you're both very clear what the expectations are, so that, you know, in a month's time, he's not improved, not engaged in the physiotherapy or the exercise physiology or that you've organised, then you're not going to be willing to continue to alter his medication. You're going to have to go back and renegotiate your treatment plan. And that needs to be very clear with measured paced goals. I would look at giving you information about consumer support groups, maybe Tai Chi classes. If you do any pain program in the state, that is the exercise they recommend for just getting people mobilising. And then I'd kind of look for other wins. You may find you know, his weight is a major issue in terms of OSA, for example. His combination of being opiate tolerant means he's got a 23% chance of having obstructive sleep apnea and a 33% chance of having central sleep apnea just because he's on opiates, let alone his weight. So that is very
quite significant.
The medication he's on. And so maybe addressing his weight gain and looking at something, so he would be eligible for Saxenda, for example, and maybe you can have a quick win that builds a bit of confidence and moves him somewhere apart from the skeptical view that he's not being listened to. I would certainly give him a very small supply of opiates, very controlled and very followed up. And the plan being, you know, I'm going to see you every week. We're going to do this. We're going to move through these goals. It is really important to realise that this new legislation that the QScript is coming under will require all prescribers to have a documented consent, a documented plan, and you to access QScript. So it's probably worth quite early having those things in place. And often they really want you to have those agreements about one prescriber with those patients as part of that process of bringing your patients on board. And that's really going to be spelled out in the standards. And so building those practices early into your practice is probably very sensible. And make sure that that plan is documented. So it's okay to continue the opiates, but as a prescriber, as long as you have a reason that you're doing it and you have a plan for exiting or a plan for ceasing or a plan for progressing that patient through, and that all really needs to be clearly documented. You know, should there be a need for audit or concern. And the other thing I think, particularly for this patient, he needs to feel that if you go on leave or you are sick, that there is a plan for someone else, because clearly that's been an issue for him in the past. And so whether you have a plan that if you're away, that another doctor in your practice will prescribe a week's worth of the medication at its current rate, or some sort of safety net, so that he doesn't feel that he needs to go outside your practice into another prescriber, which is going to increase his risk of harm. So I think just building his confidence, giving him information that he may not know. So those light bulb moments of something that he's not heard before. Pain changes my brain, really?
Yes.
And
I think that's sorry.
About not making it sound like I think he's crazy, because that's a really hard conversation to have in 10 minutes, because that's what they hear. So that has to be very well done, and maybe even happen at the next appointment, you know, in 3 days' time. But building slowly on his knowledge and his information, and you know, pushing him maybe to ATMA's education courses, for example. They have really good contemporary education that's a $2 coin donation to attend. So there are resources he can access himself, and maybe give him a bit of locus of control by giving him, you know, some resources to tap in himself. That would be about it.
Yeah, I think that giving him the education also starts to give him that locus of control as well. As you understand something, you can start to, you know, make some changes yourself. And I think it's a really valid thing that we in the industry kind of know that pain has changed, or our understanding of pain has changed quite significantly over previous years. But I wonder how much of that has been passed across to our clients that come through the door. And I think that's a really valid point. Do you think it's difficult to establish mutual goals? I see that you've got that there and you spoke about that. Obviously, you know, often we're coming from different areas. Do you think it's difficult to establish mutual goals?
Well, to be honest, my standard appointment's 40 minutes or an hour. So, you know, doing that in 10 minutes is very small.
Yes, that's what I was thinking.
Hard.
Yeah.
But I think, you know, apart from that, he's out of medication, which is a problem to him, and that'll be the one he's focusing on. He has lots of problems, and none of his current solutions are working for him. So, you know, the goal may not all be about opiates. In fact, you know, that is on the list and always part of the conversation. But you know, the goal to
about life rather than just
walk to his letterbox twice a day, every day, as a paced activity, 2 times in the morning and 2 times in the afternoon, and then increase that over the next 2 weeks. That may be the only goal he needs, but he needs a goal, something that you can tick off, he can measure. You know, improving his sleep might be another goal, and that'll be an important one to him. That isn't necessary all focused on let's cut your opiates. It's
Yeah, and I like the idea about the small goals so that he can achieve them, feel his confidence grow, and hopefully strive to do more as well. Yeah, I like that. Well, thank you for that. Good response. I'm going to move on to Joy now. Could you talk us through some of the medication-related risks you saw with Daniel's current prescribing regime?
Yeah, thank you, Jim. Jim, I just wanted to say that I totally mirror what Geraldine and Melanie have been discussing. And I think one of the things for Daniel, and one of the things we tend to do with my pharmacy hat on, is that we look at a medication list and we define the person by their medicines. And sometimes we use language that mirrors that as well, and that reflects that. And we absolutely need to separate the person from their medicines and also allow them to feel that they are not defined by their medicines nor their conditions.
Definitely.
That Daniel has come to a point where he feels controlled by his medicines, controlled by his conditions, and we need to allow him the space and the education that Melanie and Geraldine were talking about, and the time for him to see himself as an individual and not being defined by the medicines. And that's going to take time. Definitely. Small steps in gaining his confidence and establishing that rapport and relationship is really important to do that. In talking about, I guess, his overall medicines, and in this circumstance, one of the things I was going to say is that in thinking about the clinical governance for the care of Daniel, is, as Geraldine said, setting up those timelines of when he's going to be seen again, and him understanding the nature of what those appointments are going to look like. And so if we're thinking about bringing him back, this needs to be perhaps a longer consult, telephone or telehealth, ideally not in this scenario. And I know that there are other factors that might push that, but this needs to be face-to-face dedicated time with Daniel, and not feeling as if he is being shunted about, and making those points within his notes so that if he does call reception for an appointment, there is a note in there, not necessarily talking about his medicines, but saying, this requires a face-to-face consultation, and setting that up within the agreement that you have with Daniel. I guess that's the term that I have engendered in the practices that I work with, is setting up an opioid therapy patient agreement, rather than using language such as contracts, which I think are counter to what we're wanting to achieve with the relationship we have with Daniel. And also that if you're introducing something like that, it needs to be a practice-wide approach. And as you mentioned about setting up a buddy system right from the beginning, so that Daniel knows who the other GP who knows him, who will get to know him well if there needs to be an absence of his usual GP. Yeah. Sometimes Daniel might be the person who's going to say, oh yes, I've heard of this other GP, and it might be something that he could feel that he has some control over as well. But having him feel that safety net around him within the practice is going to be really important right from the beginning. So he's on a whole range of medicines, not just the opioids. And for me, if I kind of set the opioids there, and that's obviously taken a journey for him to get to that range of opioids, possibly partly cost-driven. Perhaps the tramadol at immediate release is there because the tapentadol 50 milligram immediate release is a private script. I'll be really keen to know which one out of those does he feel actually provides him benefit? How much of the tramadol has that actually, is that contributing significantly to his oral morphine equivalent dose? Yeah. And then looking down that list, of course, most of us will feel a little uneasy with the sertraline there as well, in terms of the potential for serotonin toxicity, depending on how much tramadol and also tapentadol. Unfortunately, we've had a recent case in South Australia where we think serotonin syndrome as a result of tapentadol and an SSRI that required an ICU admission. Yeah. There were many other factors, but it was, it's kind of raised our alert that it is not a benign agent of serotonin potential, that is a tapentadol. But looking down his list, I'm really keen to know, where is he at in terms of, obviously he's in a stress situation at the moment, but where is his mental health? how well has the sertraline and how well is the sertraline managing his depression? And I'm assuming there's an overlay of anxiety. And as Dr. Chew has spoken about, are there sessions where he does go through brief periods of withdrawal that drives some of his anxiety, that then further drives medication use? I'd like to understand the journey of how he got to 100 milligrams of sertraline. Has he been under the care of a psychologist who understands both the mental health and also his chronic pain? And maybe that needs to be divided out. Yeah. When did he last have his mental health care plan? Did that run well for him in terms of the relationship that he has had with a psychologist in the past? And then, of course, his other medicines. And I can see there in the chat function that I totally agree with in terms of the erectile dysfunction. There's many other things that could be contributing in terms of his depression and what is driving what. Many of his medicines beside the opioids, both the sertraline and the pregabalin, significantly contributing to weight gain. And really interesting to know his type 2 diabetes journey, to find himself on the Ryzodeg when there may have been other options along the way, and understanding intolerances to perhaps other options. Many other aspects there, I think, that over time we could address, but I think right now, keeping Daniel safe, making him feel supported, and engendering him to come back and knowing that this is going to be a team approach, allowing him to learn along the way and feel supported.
Yeah, I think that message of trying to get the support and safety as the primary drivers for any changes, I think, is a valuable message to get across. Just because sorry.
No, I was just going to say, and it is omeprazole 40 milligrams twice a day. It is interesting as well, and maybe there's other pathology there that we don't know about that hasn't come through on the summary.
Now, just because I'm asking now a personal question, because I work in QOTP, which is, opioid treatment, and obviously whenever we see pregabalin and opioid use together, we kind of have that, the hairs stand up on the back of our neck, and we have kind of been taught that, you need to be careful with those. Is it valid that he could be on both of those? Is lower back pain something that pregabalin may use, or is there likely something else going on, do you think?
Yeah, I'll be really interested to know in what circumstance that was initiated, and over what time course has it been elevated up to the 150 milligrams, and has it been challenged on a lower dose? What is that doing to him cognitively? At that dose? And I can see that one of the comments is, could have switched to something like an SNRI, like the Duloxetine, that might have the, possibly some neuropathic pain benefits for him, and that could be an opportunity for him as well. So, unfortunately, we understand that, low back pain is challenging, and I'd really love to understand the language that has been used and what Daniel hears around back pain, post the motor vehicle accident, and the work cover claim, and how much of that is still influencing his interpretation of his current acute and then what appears to be now chronic pain from the ankle fracture. So there's so much layering there to understand.
Perfect. Thank you, Joanne.
It's really finding out why is the pregabalin there. It might be for an indication that we're not even privy to.
Yeah, perfect. Thank you. I'm going to move on with the case study. So Daniel's been progressing well with adopting other treatment modalities for his pain. So the team are obviously working well, and he's gradually been losing weight. He recently had a consultation with his pain specialist, who actually told him the reason his pain is so bad is because of all the opioids that he's been taking. And the specialist has told Daniel that in order for his pain to improve, he needs to come off all of his opioids. This understandably has troubled Daniel considerably, as he states he can't even walk without his medication, and so doesn't see any way that he's going to be able to come off all of his opioid medication. Daniel has therefore come to you to discuss this further. In checking QScript, you notice that Daniel has also been prescribed some further oxycodone and naloxone recently from another prescriber. He reports that this was because he thought his medications were about to be ceased abruptly after talking to the specialist, and he was worried about withdrawals. So Geraldine, Sorry, I shall actually go to Melanie first. So Melanie, unfortunately in practice, sometimes prescribers can be left with secondhand information and are not guided as to how best to manage the deprescribing or the changes behind opioid use. With Daniel's scenario being particularly challenging, he's currently on 3 opioids. In your experience, how would you approach opioid deprescribing for Daniel in a manner that would allow him to be on board with this plan and not increase his anxiety too much?
Yes, ceasing all opiates is you know his fear, and is definitely going to push him potentially into aberrant behaviour. And the data, particularly out of the States with the opiate crisis and Canada, where they just absolutely cut people's opiate doses like overnight, is that is the highest time for risk of harm, where patients are going to either swallow all their box or get whatever they can from their neighbour, or in fact push them onto other substances, even alcohol or illicit substances, and in their attempts to not come off whatever they're concerned about. So that is always very concerning, and sort of hand in hand with that is maybe thoughts about, and certainly the recommendations are that a patient at this sort of risk should be prescribed nasal naloxone as an opportunity, and maybe have conversations with their family member, for example, about its use and what it looks like. It's certainly a risk factor that should be considered. As far as he goes, again, back to your treatment goals. So the goal would be to not put him into withdrawal, and to keep improving his function, to not be measuring against a number of medication, but to actually continue to improve his function.
I like that.
We've already had some of those wins for him. So maybe getting that brief pain inventory out and getting him to repeat it again, and sort of, because it will normally show a change in his pain and his function, that he does, because when they're living it, they miss it. So being able to sort of quantify, look, you've achieved this much, with good support and good goals, and we can achieve more. Like this is a journey, and you've made good steps along the journey, and really making him own what he's achieved will give you the best engagement for owning what's going to happen next. Any opiate change, an easy way to do it is to opiate rotate. Ideally to one opiate for him would be good, and it gives you an advantage. So because of the incomplete cross tolerance, you should drop an opiate rotation by at least 30%, and on high dose up to as much as 50%, and you will still get better analgesia than what the patient's getting now. So there is a real benefit, and because you're dropping the opiate dose, they're not going to withdraw because the dose is 30% in that initial rotation.
Yep.
After that, you do need to slow down significantly. Sure. But it does buy a level of confidence and a different analgesic picture than the patient has at the moment. When you've got multiple opiates interacting with the receptors, it becomes quite messy to control for no benefit. So the evidence says there is no benefit being on multiple opiates. And so unless he's getting a neuropathic element out of the tapentadol that he wouldn't get out of a straight opiate, and again, that's about understanding his history a little more than we currently do, which brings me on to if you do rotate someone to tapentadol, so 20% of tapentadol's opiate analgesic action is opiate. So that's actually quite a small effect on the receptor compared to a pure mu agonist. And so occasionally people rotate it looking at those analgesic comparison tables or apps, and miss the fact that it's significantly less opiate effect, and then the patient can be inadvertently put into withdrawal. So that needs to be managed very carefully. So the tapering of the pure mu agonist, if he's still using it, would have to be gentle to cover that change across. And then maybe because he's at risk of being pushed into doing some aberrant behaviour, you would look at talking to the pharmacist and maybe getting a staged supply. So you're not handing him boxes full of medication to do something, when he panics. with that you don't want to happen. And then the other thing to bear in mind is that, you know, his other journey. So he may well by now have been to the orthopedic surgeon who said, look, there's nothing wrong with your ankle. You have to take off your moon boot. We need you to do aggressive physiotherapy. And so he actually may need his opiates or other analgesic strategies, you know, managed for this aggressive physiotherapy that he's now going to undertake to get that ankle moving, to build his confidence, to get that strength. So you can't just go, okay, we're going to do opiates, that's all we're going to do. He's far too complex for that. And he may actually need a lift in something. I might use something like clonidine to help with some pain management and also with some withdrawal aspects. I like to prescribe or encourage patients to use palmitoyl ethanol amide, so PEA, for its anti-inflammatory effects across lots of the neural system. And sometimes that can be very successful for reducing overall inflammation and getting patients to move. So giving him some other strategies that aren't necessarily around opiates, only, you know, talking about physiotherapy, planning his analgesia before he does it, including using just simple things like ice, elevation, compression, all of those things for an ankle. And really just keeping in mind that we may need to pause that opiate wean or halt it or address the new pain as he moves through this rehab process, because really that's what we're trying to encourage him to live, is a rehab process through his chronic conditions and his what he believes are his untenable pain ones.
So, thank you, Mel. Excellent. I'm going to hand over to Geraldine now. How would you approach the fact that Daniel sought out other prescriptions for his pain? So he accessed other opioids from another prescriber. Do you think this means Daniel has an underlying substance use disorder, or would this behaviour be normal or typical for somebody in his situation, do you think?
When I first see Daniel, like in the very first consultation, I would ascertain whether he has a substance use disorder in the first place. So let's say he doesn't, and that's why I've gone through with the opiate, you know, management. So, because if he does have alcohol abuse and other illicit drug use in the past, that would be a red flag, and maybe he would not be suitable for therapeutic opiate treatment, but perhaps be registered on the opiate treatment program, which is a different story again. But if Daniel came back and said he was fearful and the specialist had told him to stop taking all opiates, it may cause a panic reaction, and he's gone to another doctor to get some solace, I suppose you could say. Yeah. But I'll say to him, look, Daniel, there's only one doctor that can prescribe opiates for you. If you don't want it to be me and you want it to be a different prescriber, that's up to you. But if you want me to stay to be your doctor, you have to abide by our contract, as mentioned by Melanie, and we will work through things properly. Discuss it with me. I will not be taking you off the opiates suddenly or precipitously. We will do it gradually. We will assess and reassess how you're going with the medication, with a view to continuing to taper the opiates down, because we know high dose opiates are not suitable for persistent pain management and carries with it a high level of risk of morbidity and mortality. But it doesn't mean that I will take him off the opiates completely. He may need to be on a low dose maintenance opiate, and that's quite reasonable even among the pain specialists in pain field. So I will have to discuss that with him. He will have to agree that he won't see another doctor. If he does do, he shouldn't bother coming back to see me. You know, if I have had a rapport with him and he understands where I'm coming from and I'm there to help him, he will understand that, you know, and stay with it. If he doesn't,
you're working with him, not working against him. Definitely.
That's correct. Yes.
Do you think just because of the message that his specialist gave him, would you talk to his specialist and let him know that conversation raised that alarm, you know, in Daniel? Do you think that's a valid thing to do? sorry, putting you on the spot like that, but obviously
that scenario hasn't really come up in my field, and not many. I mean, actually, something different. I have had patients sent to me on high dose opiates, for example, a gentleman, 300 milligrams, and told to swap him to Suboxone, which is buprenorphine, by a pain specialist. Now, those who understand, the pharmacists, and it's not easy to swap someone on a full agonist and a high dose agonist to Suboxone. So that's again another story. But yes, I suppose I've had that, and then I will have a conversation with the patient and say, this is going to take some time and won't be able to do it straight away, and the reasons are such and such. Really giving the patient an understanding of what you're doing with them, what their medications are doing for them, how they might expect any adverse reactions if they should occur, how they might expect some positive benefits. You have to talk that through with the patient so that they understand and come on board with what you're wanting to do to help them.
Thank you, Geraldine. I'll go over to Joy now. Do you have any advice or tips which have helped to engage patients in the past when considering opioid tapering, Joy?
Thank you, Jim. I think it goes back to what I was saying initially, is giving Daniel a sense that he is going to have control over this, well, controlling partnership over this process, and that it will be done at the gradient of that taper is going to depend on many other things around him. And as I was saying, it's going to be so important that his mental health is in the right place, that he feels as if his diabetes management is being well controlled, has he engaged with the diabetes educator. So he does feel as if, yes, this is the focus, but it's not the only focus of his care. And that so that the overall trajectory, when you're looking over several months, which is probably what this is going to be at least, is that it is down, but there's going to be areas of plateauing, and then there's going to be areas of going down again. So I think, really engendering that partnership again. And as we've all spoken about, making sure that he does understand why we're doing this, that the end goal here is for him to be the best that he can.
Definitely, yeah.
That's why he feels at the moment that Mel says that he feels broken, but changing that perception for him, that he is a whole being and this is something that is achievable, and there have been others that have done this before him. And that's where, engaging him with perhaps some group sessions or some of the online courses, if he doesn't feel that he can do in person or not able to do in-person group sessions, to understand from others that have been perhaps along this journey. So utilising the videos that we know along on various forums that we now have available on some fantastic, chronic pain management platforms. And I think, as we're saying, in generally making sure that those other interventions, what are the other things? Has Daniel felt pleasure? Where is pleasure for him amongst this? Find where that pleasure is and keep that as the goal. Now, that may change as the taper, occurs, but finding what it is, that absolute driver for him that he wants to keep on achieving or return to, and keep that front of mind for him.
Perfect. Thank you, Joy. And I also like the fact that you were talking about this isn't going to be a quick thing, and preparing Daniel that this is going to be a slow, steady progression rather than we're going to rush this. So excellent. Thank you, Joy. So Daniel has been sticking to the agreed plan and has steadily been reducing his opioids. He's experienced minimal disturbance to his function or pain experience. He attends his regular consultations with you. At the most recent consult, Daniel looked visibly distressed. He advised you that his son left home due to family arguments or disagreements, and Daniel is clearly worried for his son and hasn't been able to sleep for about 3 days. As a result, he says that his pain has also intensified. So I'm going to go straight to Geraldine now. How would you approach Daniel's deterioration in sleep and psychological distress? And would you actually prescribe an additional hypnotic such as a benzodiazepine to assist him with these issues?
Unless Daniel specifically asked for a hypnotic, I would steer away from this option. I would sympathize with his situation and ensure that he felt that he was heard and listened to. And I would provide some counseling about sleep hygiene, stimulus controls, sleep restriction, that sort of thing, as well as to help him relieve the stress that he's under, help some brief relaxation techniques like slow, deep breathing, progressive muscular relaxation, mindfulness therapy. They're all useful in helping to relieve stress and anxiety. And you can do that very briefly. I have my little techniques. If I did prescribe a hypnotic, would probably use a benzodiazepine with a small number of tablets dispensed at a time. And perhaps in a stage supply, as mentioned by Melanie, to take judiciously. I'll say take 1 or 2 tablets of nitrazepam or temazepam. One first, it doesn't go through another one. And then if that gives him sleep, great. Don't take any for another couple of days. And if he still has this 3 days of no sleep, then he can take another dose, but not to take them on a daily basis.
Yeah, nice advice.
And he would be informed that his psychological distress is not going to just go away with brief interventions, as I mentioned, and I would refer him to a psychologist. But I think he would already have been referred to a psychologist from the outset, because from the care plans that I would do with his full participation would include, like I said, the multi-modalities, psychological treatment for pain as well as for his mental health, also psychological therapy to educate him about pain. I can give him some education. The physical therapist or the physiotherapist can do, and so can the psychologist. It's all a combined group that can do it, because we attack it, or let's not use the word attack, work at it from different angles, because pain is so,
So because he's having a rough time, you wouldn't increase his opioids to compensate for that? No,
I wouldn't increase his opiates. I can't see how it would help him.
I agree.
And if he asks for that, I'll say that that's not going to help with his sleep. It's, or necessarily, we should look at other ways of keeping his distress down, and therefore his pain will be down. Or we'll equate this distress with pain rather than alleviating the pain and then the distress, which it can do, but it's not the right way to go about it.
Definitely. Thank you, Geraldine. Thank you for that. Joy, the combination of opioids and benzos, as we were just discussing, is also identified as a possible high-risk clinical scenario in QScript, and obviously can generate alerts. For pharmacists that may dispense this combination, what would you encourage them to do to reduce the potential harms to the patients, and how should they collaborate with the prescriber?
Yeah, Jim, thank you. I think collaboration is absolutely going to be the key here. And I'm just seeing a few chats coming through that have been really good. I think in this setting, if that did happen with Daniel, and there were, irrespective of QScript, there would be a level of concern that I'm sure the pharmacist would feel for Daniel, not only in that what is happening for him to require a prescription for a benzodiazepine, but what is the advice and counselling that the general practitioner has provided? And if that isn't clear from the prescription and the instructions on the script, then I would really encourage a phone call. And this is a great opportunity to engender that sense of team care for. So if that happens, saying, look, I'm just going to double check with your GP and making sure that you are strengthening that therapeutic alliance that Daniel has with the GP by doing that, and also your alliance with that GP, and really reflecting what that advice has been. And understanding what it is. So has the advice been a maximum 3 per week, not on consecutive nights, really reflecting that. So I think having that conversation and documenting that conversation with Daniel's GP is really important. As Geraldine has said, perhaps a reduced quantity, the stage supply, which you're needing to be, if you felt that that's going to be appropriate, you need to be contacting the general practitioner for that. And look, and there may be an opportunity here, if you're having that discussion with the general practitioner around perhaps the opportunity to spend more time with Daniel through something like a home medicines review, to continue along that education line for Daniel, not only with regards to pain management and his diabetes and his mental health, but now also around sleep hygiene for him, and understanding what normal sleep is and the role that the non-pharmacological and at times pharmacological therapies might play there.
Perfect. Thank you, Joy. I guess it does beg the question, just to put you on the spot, as I picked on Geraldine earlier. Would you ever think it's advisable for a pharmacist to just not dispense? Because obviously you have a duty of care as well. And obviously if you saw combination opioids and benzos, how useful would it be as a pharmacist if you just didn't dispense the medication and sent him back to his GP? Is that a useful way of managing that?
Often not. And it's not unusual for us to get questions like that from community pharmacists to the Drug and Therapeutics Information Service saying, how do I manage this? And I said, the best way to manage this is to pick up the phone. And it may be that particular GP is not there, but often within, if it's not a solo GP practice, but if there are, if it's not a solo GP practice, there will be usually another GP there who will be willing to take the call, or a practice nurse to have a conversation with. And hopefully Daniel will either be able to wait or perhaps come back, or you'll be able to make those phone calls and call the patient back at an appropriate time. So no, not dispensing is going to be an incredibly rare option.
Yeah, thank you. And it's going to create lots of distress and jeopardize potentially what the relationships that Geraldine and the others have built. So thank you for that, Jill. I'm going to move to Melanie now. All of us have experienced times where we disagree or feel uncomfortable with another health practitioner's clinical decision making. Do you have any advice for prescribers and pharmacists in navigating these issues or conversations?
So, well, being a nurse practitioner and sort of the leading edge of that change in healthcare in Queensland, I have to communicate and reach out with health professionals quite regularly, so that the understanding of what my role is and what legally I can do. And certainly I've had scripts refused, and then had to contact the pharmacist and say, well, actually the legislation states. So, but normally it's well received. It's not done out of malicious miscontent or anything. It's really just they haven't read the changes to the legislation, they're unaware, and usually you can move forward. It's not a problem. With that, it is really important to understand that there's been a couple of cases in Queensland where the coroner has held the dispensing pharmacist, even despite the fact that they've made phone calls to prescribers, legally responsible for the harm to a patient because he filled the script. So that information is well understood out within pharmacy, community pharmacies, and so they are feeling the pressure to not fill that script unless they feel that it's a considered reasonable thing to do. So establishing rapport and ongoing relationship with several pharmacists in your area is probably a really sensible thing to do, so that they know that you review your patients, and they know that you have a plan, and they know that you wouldn't jump into these things lightly, and that you'll take a phone call, because then they're more likely to go, okay, well, we'll see how this goes. And that really important thing apart from that is our patients, unfortunately, because of this, now the pharmacist is talking to me and the doctor's talking to me, and they're looking something up on the computer, and there's more information about me on the computer, they are going to be so paranoid. They are going to be so frightened about what this means, and what Big Brother's doing, and there's all this information, and now everybody's treating me like I'm a leper. I've just got back pain. Like, we really need to be educating them and not leaving them standing, waiting in a room, whispering on the phone on the other side of the counter. It's super important that they feel that we're all part of this team, and they're part of the team too, and we're there to support them. So establishing all those relationships means that the team exists, and then you include the patient in as part of their management team. And I know those are very trite words, but they mean a lot to the patient standing at the counter in the pharmacy.
Yeah, thank you. Thank you, Mel. I don't know if that brings us to the end of the scenario as we had it. I don't know if anyone wants to add any additional comments before we actually go to questions from the audience. Does anyone have anything they'd like to say?
Jim, the only other thing I was going to say is that another thing that I'm kind of hot on at the moment is if you're looking at surgery, if he had upcoming surgery for his ankle, that would be another huge motivator to try to reduce his opioid burden. With the evidence that we now have with regards to the post-operative and rehabilitation risks, with opioids pre-surgery. So there's direct correlation between level of opioid use pre-surgery. This has mainly been for orthopedic surgery that the evidence is emerging from, and longer length of stay, increased risk of ICU admission, increased risk of infection post-op, and poorer rehabilitation outcomes. And, you know, we've long kind of felt that it's okay for those people preoperatively to remain on their opioid or remain on their dose of opioid, but we really do have an opportunity to try to minimise opioid use and dose prior to really improve outcomes. And I think that really needs to be part of their consent for the surgery.
I agree. Thank you, Joy. Geraldine looks like she was going to add something as well. I don't know if you were. If not, I'll go to questions. Oh, no, thank you. Mel, you go on.
So from an acute pain service perspective, you know, a patient who comes in on a fentanyl patch of any strength, to be honest, managing their pain post-operatively is really, really difficult. Their opiate receptors are so saturated with opiates. Getting something to be effective in that setting when we've, you know, taken parts of their body out, we really actually need them to breathe and move, and their pre-existing opiate tolerance really limits how effective what we do can be. And while we are prioritising lots of regional blocks, lots of local anaesthetic techniques, we still are, you know, there is a crossover. They can only be in for a couple of days where we need to use opiates and they need to be effective. So any decrease preoperatively is in that patient's best interest, just for that process alone.
Perfect. Thank you, Mel. We will go to some questions, and for those that are still tuned in listening, thank you. And we also have Nicolette, who's another pharmacist who's joined us, but she's focused on Queensland's QScript. So just in case anything is specific to that we need some support with, Nicolette has agreed to be here for that as well. The first question I have is actually for Joy. As you said, you work in South Australia, which has launched its version of QScript already. Can you tell us what your experience has been like of using that system?
Yeah, thank you, Jim. I'm speaking mainly from the perspective of working within a general practice because I don't work in community pharmacy. I will say that I would be
fair enough.
Community pharmacy, but from mirroring experiences from colleagues in community pharmacy, and also from a general practice point of view, it has absolutely enabled us to have very honest and transparent conversations. So it's been very reassuring in some circumstances, and it has shed a spotlight on scenarios where we have already had significant concerns and we just haven't been able to get to sometimes the
crux of it.
And I will say that word because it often is difficult to find that. And it has really strengthened the opioid therapy patient agreements as well. And it's held us to account, and it's held some patients to account as well.
Definitely, yeah.
Strengthen that alliance by having that transparency there in front of us. And for some patients, and this has only been a handful, it has nearly been a relief. Yeah. It's nearly been a relief for us to be able to see the entire picture and the truth.
Understand that.
So that's been the experience so far.
Perfect. Thank you, Joy. Let's hope we have similar here. I'm certainly excited about it. Some more questions. In addition to medication, so this is just open to anyone who wants to respond. In addition to medications, are referral to psychological supports relevant in supporting chronic management, pain management plans, for example, to access CBT, mindfulness, etc.? And I know you've already touched on that a little bit, Geraldine, when you were talking earlier, but I'll throw that out.
Can you repeat that about the psychologist?
So yes, basically, would you suggest that referrals to psychological support would be highly relevant in supporting people that have chronic pain management plans, for example, so that the client can access some skills of CBT, mindfulness, etc.?
Absolutely. Absolutely. Yeah. That's what I'll be doing. It's both for pain and for mental health issues.
Yeah. Yeah, and the two are so interlinked.
And it's a form of education as well, because pain management, the impact of psychological, the views, the attitudes towards pain is formed psychologically, really.
Definitely.
And they need to look, the psychologist can help them look at addressing their pain but the way they think about it to form, as Melanie said, new pathways. Habits are formed because we teach ourselves to follow a certain pathway, a certain habit, and we can do that with other areas as well in our life, including pain.
Thank you, Geraldine. Somebody's actually asked about a specific pain management technique. So again, I'm just going to throw it out there for you guys to know, to respond if you know about it. It's something I've heard of, but I don't know a lot about it. Somebody's asked, would you consider EFT, which I don't know what that stands for, I apologize, but it's a tapping technique for pain management. I don't know what your thoughts are on that.
I've heard of it, but I haven't used it.
Same, yeah.
The pain techniques, oh, that's right, emotional freedom. The
thank you. Yes.
Pain techniques I would use briefly, like in my brief interventions with my patients in practice, would be mindfulness therapy. So I'll say use all your senses, eyes, see, touch it. So you're outside of yourself, outside of your body, and you're focusing. So those very simple techniques is what I use, but I would expect the psychologist to do more. And that's why I would refer them on. Same with physiotherapy and exercise physiologists. I would suggest, say, going to the local pool if they're safe and well enough to do so. But they need the referral to a specialist to go more into detail.
Yeah, definitely. Thank you, Geraldine. Melanie was itching to say something, so I'll let Melanie.
I was just going to say that I haven't used or been taught EFT. I have had several patients who found it extremely useful because it's usable anywhere at any time in any place, and just it enables them to drop that stress response so that they're able to then manage and put something constructive in place. And essentially that's the message they've always given. And I think anything that allows the patient to do that, it doesn't really matter what technique that is. If it rings true for them and they're able to normalize what's happening to them and come up with a rational strategy for moving forward, that's the perfect technique for them.
Very valid response. Thank you, Mel. This one may be for Joy. I don't know. Would a switch, or to Geraldine, would a switch to Duloxetine, the SNRI, be more beneficial due to studies showing its efficacy for chronic pain?
I think I briefly mentioned that.
You did mention that, I apologize.
But it can, look, that could be a possibility. I think that may well be down the track, and it may be that depending on, as you said, response to the pregabalin, where he is with the sertraline, is this anxiety, is this depression, is this an overlay, is this something else? So it could be.
Thank you.
And I'd like to make a point that you don't need high dose pregabalin for neuropathic pain. A low dose is perfectly fine. Patients even say that it works well in 75 milligrams. That's what I would do if I give them anything. There's also, if they have a problem with sleep, just initially as well, you can use amitriptyline as long as they don't have other issues, but just a very low dose, 25 milligrams, 50 milligrams.
Is that quite a lot in psychiatry? Yeah, perfect. So one for all of you as our closing question. So the case study presented today can be quite challenging and sometimes seem overwhelming. Are there any services that GPs or pharmacists can use to help support them and the patient? And would you recommend any resources, training for health practitioners looking to upskill in chronic pain management or the management of opioids? So a long question, but what resources are you aware of that you can promote for people to access? Who's going to go first? Geraldine?
Yes, there are resources which I would give to the patients or show them. One of them that I use quite frequently is the Hunter Integrated Pain Service resource. You can just go into the net. It's free. It educates people about the pain. It's got little links that you can go to other sites as well. It's got the mind spot programs and things, links. I'll say what costs money and what doesn't cost money. So I use that. I'll Google it on your phone. GP or specialist practice computer print a little thing so that they can access it when they go home.
Oh, nice. Yeah, yeah. Nice. Thank you, Geraldine. Mel, have you got any recommendations?
The Upward program can be useful as it's free if it's referred from a clinician for patients that are unwilling to visit a psychologist. Sometimes it can progress them through some of those barriers. The NOI tools, so the Neuro-Orthopedic Institute tools, the Explain Pain resource, the Protectometer as a way of working through what the patient seems as a danger in me or a safe in me activities, trying to help them strategize through those initial fear responses and do something constructive is a really useful and is now available in app form. Some of those apps, the Calm app, for example, is fabulous for sleeping and for teaching very simple anxiety management techniques. And the basic computer program for that is free, and then there's a small cost for an upgrade.
Nice.
Radio, the sleep radio in New Zealand is useful. So the one that does the non-rhythmic music and sounds, it's free to access, and so people who can't listen to waves because it's got too much rhythm or normal music is really quite useful for that. And then the only other thing to sort of talk about is the Better Pain Management Program that's run through ANZCA. So there is a small fee and it's for health professionals and specialists. And it's a 12 online module course on basic pain management. And it's actually really very good and very helpful. And some of the Neuro-Orthopedic Institute who are linked with University of SA, they have pain education. So how to educate about pain, the newest adult education techniques and how to apply the latest neuroexcitability and neuroplasticity and bioplasticity, which is now the new word, how that all works, what that all looks like, literally hot off the press, up-to-date stuff. So they're very useful resources.
Thank you, Mel. And now I feel really bad because Mel just provided such a comprehensive list, Joy. Have you got anything you'd like to add to that?
Very little, Jim, except that I do still at times use the Brain Man videos. I usually do use them though with the patient because they're quite high literacy level and they're quite quick. And so I can't really add to many of the others that have been mentioned, but yeah, I will still at times use the Brain Man videos.